Our topic of discussion here will be the terminal complement deficiencies. Now, I talk about the complement pathway in a pretty good amount of complement deficiencies, just for the fact that it's useful if you're going through these to look at early, then middle, then terminal. So I'm not going to talk about the complement pathway in too much detail here, just enough for understanding these terminal deficiencies. But I definitely recommend, if you haven't watched about the early and middle complement deficiencies, that you should watch that in addition to this. All right, our vignette here gives us a 20-year-old African-American female college student who is rushed to the ED by EMS. Her roommate is with. The roommate says that the patient had been ill with the flu for a few days, and when she got up to get some Gatorade, she collapsed and was unresponsive. The roommate is unaware of any family history. Patient does not use drugs or alcohol and is employed part-time at Starbucks. Patient is otherwise generally healthy. She describes fevers, body aches, and one episode of emesis last night. She denies observing any signs of confusion or behavioral changes. Normal saline bolus was started en route. You note a GCS of 10/15. Blood pressure is 95/70 and stabilizing. Temperature 101.5. Respirations 18. Heart rate 125. You note a petechial rash on the upper arms. There are no symptoms of elevated intracranial pressure. Labs are ordered and are significant for leukocytosis with predominant neutrophils and a mild thrombocytopenia with 88,000 cells per cubic milliliter. Lumbar tap reveals elevated white blood cells and reduced glucose relative to serum levels. All right, so you can pause it. You can make a presumptive diagnosis here or decide what you might want to do at this point. So you should be aware when you're just triaging a patient, when you have them, getting an idea of the initial things you should do, especially when you have an emergent issue as we do here. So what are we going to do? We're going to start this patient on antibiotics right away. So we've already done the lumbar tap, so it's fine. You can just go ahead and start antibiotics right away, since it's pretty clear this patient has an infection. Why do we think she has an infection? Well, a lot of reasons. First of all, she's had an illness. Infections can cause illness, not the only cause, but it can cause this sort of flu-like picture. We also know that she's acutely symptomatic, and we also know, just based on labs, that she's got neutrophilia. She's also got signs and a lab consistent with some kind of septic process going on. Not only does she have decreased awareness, she's a little bit lower down on the Glasgow Coma scale, but she's also got hypotension, which required fluids to stabilize, and she's also got leukocytosis and predominant neutrophils, which suggests a bacterial infection. And indeed, when you get a lumbar puncture and now analyze the CSF, you see a CSF that's consistent with bacterial infection, both with the elevated white cells and reduced glucose level. So you will start her on antibiotics. We want broad-spectrum antibiotics with this presumptive diagnosis, which, in case you haven't figured it out by now, is meningitis. We want to start on broad-spectrum antibiotics, even though we have a good idea of what the organism probably is behind this, based on the fact that she has a petechial rash. And meningitis plus petechial rash equals Neisseria infection, meningococcal meningitis. And so, even though she would probably do fine just on ceftriaxone and dexamethasone without the vancomycin, we do want broad-spectrum coverage. And so we're going to treat both for meningococcal and for streptococcal meningitis. So ceftriaxone, vancomycin, and dexamethasone. Why do we start these steroids? It's just been shown that there's an increased survival with steroids in patients with meningitis. That being said, you do have to start the antibiotics. You never want to start steroids in a patient with infection if you're not also starting antibiotics too, because you'll wipe out their immune system. So she's admitted to the ICU, as she should be, especially since she's got a low GCS. She is septic, or at least is coming out of sepsis. Why do we do a CT? Okay, now I struggled in whether or not I wanted to put the CT in before doing lumbar puncture. Here's the way it works. If you're going to do a lumbar puncture in a patient with suspected meningitis, you want to make sure that they don't have any signs of elevated intracranial pressure. So you look for papilledema. Usually confusion or disorientation. Possibly you might want to do a CT before going ahead and doing a lumbar puncture. But I just put on here that there are no signs of elevated cranial pressure. If you were to get that on the test, then you can go ahead and don't worry about getting a CT right away, because time is of the essence, especially given the fact that she's got this petechial rash. We're worried about Waterhouse-Friderichsen syndrome. And indeed, when we look at the CT, she actually has signs consistent with that. And so we are worried about adrenal apoplexy. But you can do the CT first and then do the lumbar puncture if you're concerned about intracranial pressure issues. Or you can do the CT afterwards if you're not as concerned. So it's really a clinical judgment call. But if there's any signs consistent, like if, for instance, if I had this patient and I put in that the patient had papilledema, you're going to do the CT first, by all means. But if there are no signs of elevated intracranial pressure, you can hold off, do the CT after you do the lumbar puncture. Personally, I would be okay with doing the CT first, because you note the petechial rash, and you note that this patient has all these signs consistent with meningitis. At that point, you can just start your antibiotics and hold off on the lumbar puncture and get a CT and make sure that the patient doesn't have any contraindications to a lumbar puncture. However, that can compromise your TAP when you go on to do it is the most accurate test for meningitis is to get a CSF culture. So you run some risk of compromising your labs, but it's really just a judgment call. All right, so that having been said, we started her on antibiotics and steroids, admitted her to the ICU. We got a CT and it showed bilateral enlargement of the adrenals. That is another sign that's confirming, not definitively, but pretty much sealing the deal that we've got a meningococcal meningitis here. And indeed, you get medical records from her hometown. A lot of times you got college students, you're not going to have medical records on them because they come from out of town, so you're going to want to know where they're from and what hospitals they've ever been to, and so you can get any kind of records that might be significant. And indeed, in this patient, she has had meningococcal meningitis before. Now, having meningococcal meningitis once, not terribly uncommon, especially the at-risk population, college students, prisoners, military personnel who are in barracks, anybody really who's lives in a crowded environment. So here we have a college student who lives in a dorm. So that's a risk factor for meningococcal meningitis. And now they recommend that all people that are going into these environments, so college students would be probably the largest group, but also military personnel, it's recommended they all get vaccinated get the meningococcal vaccine. So that probably didn't happen in this patient, but it doesn't really matter at this point. She's got meningococcal meningitis, and she's got a history of having meningococcal meningitis before. Repeated Neisseria infections, repeated meningococcal meningitis is not terribly common. And if that happens, you should consider an immunodeficiency. Namely, where do we see immunodeficiencies that put you at risk for Neisseria? It would be the terminal complement pathway, or the middle complement pathway for that matter. So we do, you would probably at this point consult an immunologist, but you know what tests you can do. You can do a CH50, which is sort of your overview of the complement system. Doesn't really give you any specifics as to what complement component is deficient, but it gives you an idea of if there's something up with a complement deficiency, and we find out that it's well below normal. Complement CH50, if you get that, then you know there's something wrong with either the classical pathway or the combined pathway. We know that that's well below normal, so at this point then we can go ahead and work up for specific complement disorders. Now, why would we go straight to a C6? That's really just a pearl. First of all, you know that patients with lupus, for instance, they're more likely to have something wrong early on, so C1, C2, C4. Patients who present with Neisseria infections are more likely to have something a little bit later, so maybe C3, C5, and then C6 through C9. This is an African American patient. Now, I hate using these stereotypes because it's not always this way. But on the test, it is going to be used. They like to use stereotypes. And in general, for clinical practice, if you do have an African American with repeated Neisseria infections, then yes, C6 would be the best complement test to go to if you already have a CH50 that's documented below normal. So a C6 would be the first place to go, and we were lucky enough here to find out that it is low, and so we can make the diagnosis of C6 deficiency, which certainly predisposes a patient to meningococcal infection. So this is a meningococcal meningitis with dissemination. She was septic, she had petechial rash, she had either some swelling or a mild degree of adrenal apoplexy, and this is all associated with a C6 deficiency. So our terminal pathway down here, our way of forming terminal membrane attack complex really starts out with C5. And the whole goal of the classical, lectin, and alternative pathways converging on C3 is to form not only C3b, which opsonizes pyogenic bacteria, and to a lesser extent enveloped viruses, but it also forms a C5 convertase. And C5 convertase is then used to convert C5 into C5a, which helps with making inflammation, and C5b, which is going to form the basis of your terminal membrane attack complex. So if you are lacking in any of these, but specifically if you have a deficiency of C5 or C6 through C9, you're going to have difficulty forming the terminal membrane attack complex, and that's going to predispose you to Neisseria infections. However, you can be predisposed to Neisseria infections with C3 deficiency, because if you have a C3 deficiency, then you're not going to form a C5 convertase, and that's going to affect you down here. Now, with the C1, C2, C4 deficiencies, and with issues with the alternative pathway factors, you don't necessarily develop increased susceptibility to Neisseria infections, because remember, if one pathway is damaged, the other pathway a lot of times can pick up some of the slack, enough to the point where you can fight off Neisseria. So this is our membrane attack complex. Membrane attack complexes are formed by C5 through C9. They form in this sequential way, but ultimately what happens is you get a C5 through C8 complex. C8 kind of sticks itself into the bilipid layer, and then, or lipid bilayer, and then what that can do then is polymerize C9, and C9 forms sort of the outer ring of your pore, which is a membrane attack complex. And the membrane attack complex is basically just a hole that can be put into gram-negative bacteria, and that hole then allows for fluid to swell up the bacteria. So you can see here extracellular fluids coming in through the membrane attack complex. All right, now this is not significant for immunodeficiencies, really, or for the patient at hand here, C6 through C9 deficiencies. However, it is important when you think about a specific illness called paroxysmal nocturnal hemoglobinuria, and I talked about this in the hematology section. You have something that, now remember that all of this complement stuff, it's great, it's part of your innate immune system, but one of the problems with your innate immune system is that it's kind of stabbing in the dark. You don't, without help, you don't know if you're killing your cells or invading pathogens. So you need ways and mechanisms to keep your host cells safe. And indeed, we have evolutionary mechanisms that have evolved, and we are able to keep most of our host cells safe. Of course, if we can't, if there's a problem there, then you run into autoimmune disorders. But we have a couple ways of protecting our host cells from the membrane attack complex. One of them is called decay accelerating factor, or you may see it written out as CD55. And CD55 prevents formation of the C3 convertase by preventing the conversion of C2 into C2a and C2b at appropriate times. And it also prevents the activity of C5. So in essence, what you have is at particular points in the body, you have this decay accelerating factor which puts a brake on the complement cascade, and it prevents you from killing your own cells. Now, the body is very good at knowing where to express this protein and where not to express this protein. However, if there is a problem in that, then you can kill cells that should not be killed. Another important one is something known as CD59. And CD59 exists, or should exist, on your red blood cells. And CD59 is a direct inhibitor of the membrane attack complex. It prevents the membrane attack complex from adding itself onto cells. And because this exists on your red blood cells, you're not going to complement your red blood cells and insert membrane attack complexes on them, which you can imagine would be devastating to the red blood cell. Patients who have paroxysmal nocturnal hemoglobinuria will have a problem either with this decay accelerating factor, expression of it, or expression of CD59. So that's what causes the, and I talk about paroxysmal nocturnal hemoglobinuria in a little bit more detail, and I'm not going to get into it right now, but these patients, they have problems with abnormal lysis of their blood cells. The reason it's nocturnal is because their oxygen level goes down enough to where this process can be accelerated enough to the point where you have clinical manifestations. But this is the basis of PNH. Okay, back to immunodeficiencies. So we're talking about C6 through C9 here. All of these are going to increase your risk for Neisseria infections. They're going to drop your CH50 to near zero. You should know that C6 is very common among African Americans. I believe it's like 1 in 1,500. So it's pretty darn common. And then you can see CH deficiencies as well. That you see in Caucasians too, but there is also an increased incidence in African Americans. And then C9 deficiency. This is going to increase your risk for Neisseria infections modestly, but it's also going to diminish your CH50. Now, why does C9 only do it modestly? Because if you have C9 deficiency, you can still form a membrane attack complex, because you do still have some C9, but it's just you're not going to be able to form as many. Remember, C9 is your that polymer that forms the ring of your membrane attack complex. So this, oh, I did not want to talk about this here. Okay, so all right, so we'll just go ahead and talk about C6 deficiency. So C6 deficiency is one of the more common complement system deficiencies, and it is seen more commonly in African Americans as well as people who live in South Africa, people who are from South Africa. And I'm not sure if that's the black population there only, or as we saw with another complement deficiency, C3 deficiency, that there's been a founder effect among the Afrikaans population, which I believe, correct me if you're from South Africa and I'm getting this wrong, I believe that's like the Dutch population in South Africa. But anyhow, C3 deficiency is, I'm probably wrong about that. Geography is not my strong suit. So look up Afrikaans, Afrikaans, but it's a population in South Africa. Founder effect causes them to have C3 deficiency, but that might be what's going on in C6 deficiency, because what I read was there's an increased incidence in South Africa too. Okay, so geography aside, C6 deficiency is seen more commonly in African Americans, and as you can imagine, it has a high association with Neisseria infections, including meningococcemia, as we saw in this patient, meningococcal meningitis, as we saw in this patient, and then also if they get Neisseria gonorrhea infections, they can get disseminated N gonorrhea as well, and they can have really nasty, and gonorrhea is nasty the way it is, but they can have, it can be much worse for these patients. Now, interestingly enough, these patients, when they get meningococcemia and they get meningitis, they tend to do better than patients without C6 deficiency who get meningococcal meningitis. I don't know why, but that's what the literature says. Other terminal complement deficiencies. C7, very few reported cases, theoretically associated with Neisseria disease. The cases that are in the literature, the very few cases we know of, they are associated with Neisseria disease, but this is quite rare. C8 deficiency is a major cause of terminal complement deficiency of Caucasians, but also has an increased incidence of African Americans. If by chance this had happened to be a white patient rather than an African American patient, you're going to get C8 levels instead of C6 levels. If you had to go to one to pick one or the other, And actually, I would say not just a white patient, but Asian patient, Hispanic patient, uh, anybody but an African American. So it's African American presenting with, like this patient did, you go ahead and get C6 because that's more common specifically in that population. Otherwise, you get a C8. You certainly, if the C6 is normal, then you would go ahead and get a C8 in that same black patient that you had. But C6 would be where you'd want to start in black patients because, like I said, it's about 1 in 1,500. It's pretty common. Not all those patients are going to manifest, though. C9 deficiency. This is rare in the US, but it is seen with high frequency in Japan and Korea. Not sure how that translates to the Asian American population, the Japanese American population, Korean American population here in the US. But within the country of Japan and Korea, which, as you know, has a pretty homogenous population that are within that ethnic group, it is about 1 in 1,000. So if you were practicing in Japan or Korea, which is not going to come up on the USMLE, but if you were, then probably C9 deficiency would be where you'd want to go first. Now, this is very common, 1 in 1,000, but the penetrance varies. So not all patients who have the deficiency are going to have serious symptoms or manifestations. And as you can imagine, this is also associated with mycerial disease. Okay, management of these. What do we do? There's really not a whole lot of things that we can do. As you can see with a lot of the complement disorders, they're genetic. You can't really replace anything. So what we do is we manage the symptoms and try to reduce their risk for infection. And because a lot of these patients typically don't have autoimmune issues, their early complement system is intact, they typically don't have problems with autoantibodies. Generally, what we're most concerned about are these mycerial infections. They're typically good with dealing with pyogenic infections because they don't have any problem with opsonization. But they do have difficulties with mycerial infections, as we saw. Now, the recommendation is, at least from what I got from the literature, is that they are vaccinated every 3 years. That's more frequent than we would generally give to anybody else. But it seems that they benefit from hypervaccination. It's probably just because it increases their levels of antibodies, because that's going to that will help. If you have a problem with your innate immune system, it's better to kick up your cell-mediated immune system if you can. So that's what we do. We try to overcompensate on the other end of things because they have this deficiency in this necessary complement. Now, a note on meningococcal vaccination. If you are a family practice doctor and you've got teenagers that are going to be going off to college, you're going to get them vaccinated with the meningococcal vaccine. It is so important. Anybody who's going to be living in a crowded setting, so college students, prisoners, people going off in the military, they are at very, very increased risk compared to the general population. They're at significantly increased risk for meningococcal meningitis. And who are the people that this tends to kill? It's young adults, and it's probably not owing to immunodeficiency in most cases. It's probably owing to environment, to the fact that they're around other people, and this tends to happen in those environments. And when you think about it, anything really that kills anybody, but especially things that kill young adults, you really want to make sure that you're doing something about that, because the number of patient years that kills off, and these are otherwise healthy people, and you hear about this on the news, outbreak of meningococcal meningitis or meningococcal outbreak affects local college. You hear about this, and one of the best ways we have at combating this tragedy is vaccination. And I know that you're going to run into people that say vaccinations are awful, they're the devil, they cause all these things. You get sick from the vaccination, and what they're probably referring to is, that sort of that process that occurs immediately after a vaccination, where you can get flu-like symptoms and stuff. Totally harmless. This anti-vaccination movement is going to kill more people than it could ever hope to help. So make sure that you're insisting on the meningococcal vaccination for anybody who's going to be going off into these environments. As far as prophylactic antibiotics, I didn't find any studies specifically addressing patients with terminal complement deficiency and giving them prophylactic antibiotics, simply because, I did see it for C3, and it's probably they recommend it for C3 because they're much more immunodeficient. They've also got a susceptibility to pyogenic infections. However, it may be the case that you run into a study that does recommend prophylactic antibiotics, and if you do, it would probably be something like ceftriaxone. But as of the literature that I have reviewed, which is relatively recent, there is no study that has examined the use of prophylactic antibiotics in patients with terminal complement deficiencies. If you have any questions, go ahead and write me a note below.